And so um, the most important thing that we can do as doctors is attend to those social and interpersonal issues. The other thing is to distinguish between self-harm that's not suicide directed and self-harm that is. And the vast majority of your patients who are self-harming won't be doing that with suicidal intent. And while there is a small increase in risk of suicide among the population who self-harm, the vast majority of people who self-harm don't go on to commit suicide or even attempt suicide. So it's so better to think of non-suicidal self-harm as um, a coping mechanism, perhaps not a very healthy one, but not a terribly unhealthy one. So it's much more dangerous to engage in drug and alcohol use as a coping mechanism than it is to engage in self-cutting. So try not to be panicked by patients who cut themselves. That doesn't mean that they're at great suicidal risk. And what they need is validation of their distress and understanding and um, recognition of the fact that this is a manifestation of um, coping with some adversity. Um, Over to you, Sam.
Okay, hello everyone. My name's Sam. I'm a GP originally from South Wales in the UK. I moved over here a while ago, and I work in general practice in Adelaide Hills. I also work within the Hospital Avoidance Service and also for Adelaide Uni on this research project. Um, the thing which I think is really interesting is that we, as general practitioners, we entered into the world of general practice because we liked all the different avenues which general practice offered us. But over time, and with the change of the world after COVID, but also with the increasing pressures of the world around us, we're seeing more and more mental health consults. And in fact, the RACGP estimates about 40% of our consults during an average week will be related to mental health. You could argue, depending on your circumstance where you work and your demographic of patients, you might be seeing significantly more, perhaps significantly less. But on average, that's what we're seeing. And so it is really important when we're working in general practice that we actually upskill in this area, because I'm sure you would have found those interesting comments John just introduced to us is very informative. Certainly, as a general practitioner myself, there was always this feeling of pressure that you have the responsibility to really be the one who prevents someone from committing suicide, which is often a big burden on us when we're consulting with patients, and something we're thinking about a lot. So it is a good chance for us now to spend a bit of time to consider some of the information about how we are diagnosing patients, how we should be managing patients, what would be the most suitable method of managing when they come in to us in acute distress. And if you've got any questions throughout the course of this, please feel free to put them up in the question and answer box, and I'll keep an eye on that, and I'll feed them back to John as we go along.
So if we think about patients who come to you where employment's an issue, either they're unemployed or they've got um, poor employment circumstances, we want to interest you in taking a really active approach with um, thinking about and addressing um, employment rather than thinking that it's somebody else's business. So hopefully by the end of the session, you'll feel um, not only that it's your business, but that you've got constructive things to do about it. And so we want to look at different kinds of language we can use to talk about people's distress. We want to emphasize the importance of um, the social determinants of health, the fact that it's productive to go looking for people's social circumstances rather than feeling daunted by that. And we want to really push the idea of watchful waiting as a constructive intervention, very different from doing nothing. So just to look at language first, and uh, this book that's recently been published by members of our team, um, we think it's more productive to talk about what people are going through as distress rather than rushing to give it a medical label. And when medical labels do come along, we think that talking about disorder is not as constructive as talking about a reaction. So if I say that somebody has a depressive disorder, I'm closing off the discussion more than if I say somebody's having a depressive reaction, because calling it a depressive reaction invites the question, so what's it a reaction to? And most people who become depressed are becoming depressed because of something. And rather than thinking, do they meet diagnostic criteria for a depressive illness, it's more constructive to think, what is it that's the predicament that has resulted in this person becoming depressed? What might have happened in their life to explain their distress? And particularly in relation to the children that I see, as parents, we're wanting our children to feel good, and we're not giving enough time and space for them to develop the capacity to be good at feelings, to tolerate, to understand, to be able to express uncomfortable but healthy feelings like sadness, worry, shame, anger. These are all feelings that it's healthy to be able to deal with. And too often, people are coming to us saying, I don't want those feelings. I want to feel good all the time. And part of our approach to people is to be able to tolerate and help them to tolerate some of these uncomfortable feelings. So if we just look in the spotlight for symptoms and diagnoses, we'll miss out on things that might be revealed in the shadows. So if we look at this young person who looks pretty miserable, we'd be inclined to make a diagnosis of depression. But if we look in the shadows and discover what her story is, we might reach a rather different conclusion. We might decide that this girl's miserable because she's living in this environment where there's a toxic marriage. And whereas all we can do about the depression is respond with symptomatic measures, when we know that there's family violence, we can take a different course of events, which won't just ameliorate the symptoms, but will deal with the underlying causes. Because of the time, I'm not going to spend any time on some of the myths about social determinants of health, but we do tend to develop a fairly negative attitude to people when they don't appear to collaborate with our treatment. And it's really important to bear in mind that there may be social circumstances that are preventing them from engaging. So you've got long waiting lists for your appointment times and somebody doesn't turn up. That's very frustrating. It appears like they're neglecting their health. But if that happens to be somebody who's working in a a, a job where they get called in for casual shifts and that's the only work they get, then they may have to give priority to going to work rather than coming in for their appointment. I really want to push the idea of the genogram as a way of finding out about people's social circumstances. So if we've got a patient who's working as a courier, got irregular work, and you're treating them for their unstable diabetes, then what you can expect is going to be very different if they're in a stable marriage, their partner's got a good income, they're well enough off to send their kids to private schools, they're getting lots of support from well-resourced grandparents. That's very different from if Sid has a disabled wife, his children are in trouble, and he's responsible for the care of his dementing mother. What you can expect of the patient in those circumstances is going to be very different according to their family structure. And I feel like if you don't know what's going on in the family structure, you're at a real disadvantage to treating your patient. in the first scenario, then you can really go for optimal management of SIDS unstable diabetes. In the second scenario, you're really looking at harm minimization to try to help protect Sid from some of the worst consequences of his diabetes. The kinds of questions that you might ask in order to help to discern whether there are social or interpersonal difficulties underpinning the presentation. Just to ask this simple question at the end of a consult or at some time during the consult, apart from the reason you've come to see me today, is there anything troubling you? Or anything that's happened since the last time I saw you that's troubling you? How's work? Work can be a source of great nurturance, or it can be really toxic. And knowing about where work sits with your patient can be really helpful. And in terms of a screening question about whether poverty is playing a part in the challenges that the family are facing, do you ever have problems putting food on the table is a really nice screening question to know what might be going on there. Just want to talk about the prescribing epidemic. There's more antidepressant medication and even antipsychotic medication being prescribed than ever before. That's partly because patients come to you with a pre-existing wish to be on medication. It's partly because the information that you're fed about psychiatric medications is overselling the benefits and not properly acquainting you with the harms. And thirdly, once people get onto medication, it's very difficult to get off it. So there are a lot of people who've perhaps appropriately been prescribed medication, but are now stuck on it because as soon as they try to withdraw from it, they get symptoms that are misrecognized as a re-emergence of the problem that put them on the medication in the first place, but are in fact withdrawal symptoms, just like you get withdrawal symptoms from alcohol. And so really strongly recommend the Maudsley deprescribing guidelines, which will help you with the difficult but rewarding task of getting people off medication when they no longer need it or no longer want to be on it. We really want to push this idea of watchful waiting. When I see somebody with depression and I can't find anything that I can directly do to ameliorate that depression, there's no obvious family dynamic or something else going on that I can directly deal with. So I might say to the person that depression's not a bad label for what you're going through. It describes the experience, it doesn't explain it. Usually we can find an explanation, but perhaps we won't be able to here. But the good news is that depression tends to be self-limiting. The average episode of depression lasts about 3 months. You've already had it for a couple of months, so it's likely that it'll be coming to an end soon if we don't do anything. But there are some things that we can do to hasten this process, and they don't necessarily involve medication. And Sam will talk about some of those in a minute. But what we're really offering in that process is developing an understanding of what the person's predicament is. We're building a relationship, which is the most important medicine that we've got as doctors, is the relationship that we have with our patients. We're validating their experience. We're not as popular as we used to be as doctors, but we still mostly are regarded favorably by our patients. And so when we say to them, I can really understand why you're struggling at the moment. Your work is really difficult. There are problems that you're having in your relationship. So that's enough of a reason for you to feel like you are feeling at the moment. And just saying that can make a difference to how a person feels. Offering the ongoing engagement with the patient is really valuable. We don't get to the end of um, our assessment and say, so off you go. We say, come back and see me in a couple of weeks. And if things are difficult in the meantime, if things get more difficult for you, make contact and if I can't see you, at least we might be able to talk on the phone. And what we've got on our side is the process of natural recovery. So here's a graph that I usually show to demonstrate that even in the most favorable of circumstances, um, medicine is not much better than placebo for the treatment of depression in young people. But what this graph also shows is the very major impact of time and support, because the people in these drug trials who've not had the drug, but have had the support of the people that are conducting the trial and have had some sense of optimism about the fact that they're going to get better, do really well. So just the process of being with a patient, seeing them through the process, is highly likely to have positive benefits. So over to Sam.
Yeah, thanks, John. So I think the key is really that we're not trying to explain all these concepts with the mindset of increasing workload. We're giving this as an opportunity now to kind of improve how we're managing these patients, and also hopefully make it easier, and we get more confident in when we do manage these patients, we can do it more appropriately. So when we're thinking about watchful waiting, it doesn't have to be that one, you treat them all at once. And I know what it's like, that pressure of feeling that the patient wants to come in to see you. And if you're a private billing practice, they feel like they're paying for something. But what we're trying to highlight is the doctor is the treatment here. And it's that watchful waiting that you need to connect with them, and if you're understanding, but then you can review them, and having that review over an X amount of time is really key. But we're not just doing that watchful waiting approach. We also want to add in other elements of treatment, and specifically we're thinking about the social prescribing options, really. So if you see someone in their context and think, well, actually that person is going to need some help on a number of different avenues, perhaps they are out of work, and when we're considering the risk of someone who might want to think about suicide, being out of work is a big, massive risk factor for that. And obviously being out of work, there are financial constraints. And so having good access to financial counselors is useful. So you could signpost the patient to a financial service, and we're going to put the links up to some of those at the end, where they can get free, accessible advice from a qualified financial counselor to help them through current circumstances which they might have just found themselves in. We're also going to consider that question. Are you struggling to get food on the table? Well, if you are going to ask that question, it's important that we then do the follow-up of saying, well, have you considered these things? And so it's a little bit of training and learning for us as general practitioners to know what's in our area. So if we're going to ask this and try and improve how we're managing them, we need to know what's available. So there is a food bank in this area, and this is how you access that one. Or if you're having issues with your housing, or you need some support groups, so there is a men's shed or a men's blokes club who meet down in the community centre down the way, roughly when it is. And so a little bit like collating information within your area can be useful, but there are also some websites which can do all of that for you as well, which we'll show towards the end. And then also being aware of the non-pharmacological treatments, pharmaceutical treatments to improving your well-being. Thinking about going out in nature. So in the UK, it was very common when I was working there to give someone a nature prescription, or there was something called the bikeability scheme, where you could give someone a little prescription. They can go off and hire a bike and go for a bike ride. And there are increasing social prescriptions with activity happening in Australia. It's still up and coming, but in certain areas there's more and more going on, and being aware of that, it's a really good tool to facilitate how you manage those patients. And by improving their wellness and their well-being, by looking at nature and that sort of thing and exercise, you can improve their other problems which are coming about. So, for example, they've got sleep problems, lack of energy. By doing exercise, by doing activity, it helps treat all of those as well as the mental health issues. Perhaps the next slide. Yeah, so the other thing is when we take people out of work, I often will explain to them if they are needing time away from work, for example, if it's stress-related employment issues, sometimes appropriately you would give them a certificate and trying to give them things to replace what they're doing at work so they can kind of get good structure in their lives. Well, the same goes for those people who are already out of work as well. So what is their activity like, and have they got a good sleep-wake pattern? Have we looked at what sort of social connections they've got going on in the day? Who are they meeting with? We don't really, obviously, hand on heart, think that giving a patient a certificate to go and watch Netflix for 2 weeks to catch up on the latest season of Yellowstone or whatever it happens to be is a good treatment plan. If they're just going to stay there all the time, they're obviously going to get worse. So it makes sense that we got this good sort of structure in place, plans for activity, things to get out in nature and connecting with those around them. Go to the next slide. So I alluded to this earlier on about the social prescribing resources, and please feel free to put questions up here now if there's something particularly in your area which you think we could help with. That's my Adelaide Uni email address there. But some of you might be aware about this website called Ask Izzy, and if you don't, it might be worth making a note of. This is an all-Australian website, and you can put in your sort of postcode or your demographic and see what resources are available in your area. Now, it's a very I would consider a very superficial look. It's good if you've got nothing else, because it doesn't capture everything, because it's a massive resource, and sometimes the information isn't always currently massively up to date. So there might be a new charitable sector which has just opened up in your area, which is doing some sort of scheme. So then you might want to find out about that yourself. So within your practice, as a group of GPs, maybe you guys can have a think and discuss with your practice manager to say, well, how can we work on our healthcare navigation here and our social prescribing resources? Have we got flyers? You can there's different things you can do. You want to upskill yourself on what is around the area, and there's a bunch of different information here on this slide, which you can see with regards to the financial counsellors there, which you can engage with from a South Australian point of view. But this is definitely not an exhaustive list. There's so many areas, even in Mount Barker compared to the city, there'll be a hugely varied sort of resources available. So I'm happy to hear any sort of questions that people might have around this as we're going.
And the other thing that we have available, service that we have available through this grant is that Sam is available to work with you and or your practice to improve the resources that you have available to you as a practice. Sam has capacity to do practice visits or to meet one-on-one with individual GPs. Each time that happens, it adds to the collective wisdom about approaches. So we really value the opportunity to collaborate with you to improve both your understanding and our understanding of what's practical and what is useful in the general practice setting in terms of dealing with the interpersonal and the social, as well as the medical. So just to come back to the issue of suicide, because we haven't talked very much about suicide directly, and I think the message is that what we can best do to contribute to a reduction in suicide in our community is to have an impact on the things that increase the likelihood of suicide, and they are primarily social and interpersonal things rather than medical things. Of course, if you're confronted with an individual who is expressing suicidal feelings or who other people are very concerned about the possibility of suicide. In no way are we suggesting that you should be neglectful of that or say there's nothing I can do about that. In those situations, you still need to make your own assessment and try to help the person to recognize what other options are available to them and what sort of coping mechanisms might be strengthened in order to take a different approach rather than going down the pathway of being self-destructive. And of course, part of that involves having an appropriate referral network and making use of emergency departments and those kinds of interventions. But what we want to reinforce is that's a very small part of the contribution that you as GPs can make to the overall task that we have as a community to try and lessen the likelihood of people ending their lives or attempting to do so. So we'd love to engage in some discussion and hear some questions. We've probably rushed through things a bit because of the late start.
So there's one question here. It says here, I try to universally prescribe the various plus interventions you're talking about, including sleep hygiene, lifestyle interventions, diet advice, substance use modification, etc., that you're talking about. But uptake/compliance is very low when I follow up with them. There is even the case when the interventions are fancy but paid for by someone else, e.g., employer health promotion programs, employer psychology. Any tips for actually increasing participation with these? How to sell these interventions to patients? And then Diane writes, I agree, many of us GPs do this already. There's often low uptake. Yeah, it is an issue. And, I think it's, I think we've got to make sure we're not just saying it in a prescriptive way that you would say the same thing to everyone. I think having an established relationship with the patients and working on a tailored approach and also discussing it with them whether it is suitable for them and would they be considering it. And we can't make people engage with these things, but it's an important point to highlight these and maybe follow them up. Maybe there was a reason why they've not been doing them, and then to kind of establish what the issue is and sort of revisit it. And maybe there might be another approach which would work better for them because not all social prescriptions will suit everyone. But it is a real issue. But John's got something to say about it as well.
Well, I think part of when it goes wrong, I think is when patients perceive that you're presenting this to them as a solution to their problem. And I think if you frame it in that this is to ameliorate some, if we take the issue of employment and the activation that that Sam was talking about before in terms of replacing the benefits of him. So employment provides us with income, obviously, but hopefully it provides us with more than that. It provides us with structure, it provides us with relationship, it provides us with meaning and routine. And so if I tell somebody that exercise is a good treatment for depression, I'm less likely to get a positive benefit than if I say exercise is something that's going to augment what we need to do about your depression. So I guess really in a long-winded way, what I'm saying is that it's important not to try to oversell these interventions. And there's also a distinction between something that is designed to enhance people's overall well-being, like joining an exercise program, and something that will actually directly address what is an identified problem for the person, like financial counselling. so that if somebody's under financial duress, then there's a much stronger incentive to do something about that than if they're not looking after their health through not exercising enough and you're trying to get them to join an exercise program. Um, yeah.
Any other questions, guys? I think John's point at the end is very important as well, and we're not trying to absolve ourselves from any sort of responsibility with the suicidal patient at all. It's more a case of just like looking at how we actually are managing those, and so it is still important to utilize the emergency and crisis teams in acute suicidal, like with very high risk suicidal ideation. Yeah, looking at how we can get these other structures in place will help with patients who aren't quite at that stage, and obviously hopefully help prevent others getting to that stage if they've been high risk in their social circumstances. Out of interest, has anyone here actually used Ask Izzy or use any other tools which they find particularly useful? I know there's some good ones in different areas I've looked at, but we couldn't put them all on the slide. But if anyone's got any particular utilities they love to use and find really useful, that's always good. I see it like when I used to be training my registrars, sometimes I'd just take them into the chemist next door and say, okay, well, you need to have a look at all the different creams on the shelf, have a little look at all the different antihistamines and all the different products here, and sort of just like get to know what it is, and so you know what is available, and learn what is available out there on the community over the counter by brand and trade name, whatever you want to call it. And I think the way I'm seeing our attitude to social prescribing now is it does require us all to be a little bit more upskilled in managing this. We're seeing an incredibly big surge in mental health management, and we need to actually take the time to know what's available. And we're trying to work with different services to get better single point of access because with regards to information. But it would be a good like sort of research thing to do with as a practice, I reckon, as well. And like John said, I'm happy to come out to practices and look at what's in your areas, what we can do to facilitate that from our point of view. So if you need anything like that, feel free to reach out and get in contact with us. Okay, a couple more questions here. Thank you, guys. Start for the first one which I got on the list. It says from Diane, I work in Carl and Catchant. Anglicare seems to have many wraparound resources in Adelaide and surrounds. There seems to be a lack of community social work, unfortunately, which would be useful for patients. And I would agree with that. Don't John add anything to do with that, John?
Yeah. I guess I mean, it would be great if we could, if there were social services that we could readily refer to. I wouldn't underrate what financial counsellors can do. If obviously there needs to be a financial focus to us to get a ticket to a financial counsellor, but they do more than just provide their counselling in their area of expertise. Are also very well informed about resources in the community, and so that if the person gets to a financial counsellor and there are issues of family violence or housing insecurity or food insecurity, those kinds of things, then the financial counsellor will often be able to um, uh, provide the patient with support in those areas as well, or direct them to resources for those areas. So in a way, it's a kind of proxy social work referral to refer to a financial counsellor.
Thanks, John. And then this next one from Alex says, please disregard if not relevant, but many of my clients with work injuries will sometimes not have their claim accepted, so they can have an injury, but also not be able to return to work or receive income support. Often in these situations, the worker becomes very distressed and can talk about suicide. To engage the doctor quickly in these times can be challenging, but I think it would be good if doctors were aware of these particular situations as well.
Yeah, I think it's a really difficult, like that's a kind of um, very high risk scenario, isn't it? Because in addition to losing the structure of work, the financial reward of work, um, their situation's been invalidated. They've been told that um, um, they're not actually worthy of care or being looked after. And so we can, to a limited extent, try to reverse that invalidation by acknowledging and helping them to make sense of that situation. But to recognize that as a very high risk situation and again, um, it wouldn't be unusual for people in this situation to be in financial difficulty, and connecting them up with a financial counsellor um, might ameliorate some of the concerns. But yeah, just to acknowledge that it's a really high risk situation.
The other thing which I think we've also been thinking about is the quality of our mental health care plans and how we're getting through those, and the information, because sometimes there is a pathway which we're almost inclined to do because of Medicare, and then patients often will come in saying, I just want to come in for my mental health care plan. And inappropriately, I'd say fairly regularly, I'll have someone who's a new patient joining in and wanting a mental health care plan straight away, which we know is not what we really want to be doing. And so looking at the quality of our referrals, because it's the sort of a process, sometimes you only get out what you put in. I know sometimes, myself included, sometimes not always written the most wonderful mental health care plan, and just thought, well, hopefully the psychologist will work it out. Now, the benefit to the patient is so variable on their relationship with the psychologist, and it might not even be what they particularly need. So yeah, having a moment to think whether a mental health care plan is even appropriate is also a question for when we see these patients.
Yeah, I think that the idea we kind of think, well, um, I lack expertise in this area, and there's somebody over here who has greater expertise. So it makes sense for me to pass the person on to the expert. But what you have is relationship, and sometimes relationship trumps expertise. Um, and so it may be more beneficial to the patient for you to engage in a watchful waiting, building a relationship, continuing to work with the patient, even though you may not feel that you have any specific treatments to offer. Offering that relationship might be more powerful.
Okay, guys, any more questions at all?
Thank you for persisting and hanging around until we got started. I'm sorry we rushed through things a bit under the pressure of time, but I think the most important thing is that if there's anything that's come out of today that captures your interest or curiosity, that Sam's available to support your further thinking and reflection about dealing with the interpersonal and social aspects of your patients' lives.
Thanks, guys. Feel free to get in touch.